little bit of school law, and a whole lot of workers' compensation. So most of my practice is representing people who've been injured at work. Our goal here today is going to be to go over Wisconsin's work comp system so that you as practitioners kind of know what is happening in the lives of your patients and kind of as they go through the whole system and what you can do to advocate on their behalf. We'll go over a little bit of the history of work comp, kind of the overall process, what they're going to face, some issues that you might need to address representing or treating injured workers as opposed to people who come to you otherwise. And then we'll get to the big cheese at the end, and that is the WKC 16B. And we'll spend a fair amount of time kind of going over that because that, I think, it's, first of all, the main place that medical providers come into the work comp system, and also it's where people get tripped up a lot. There's a lot of questions on there that aren't worded in a way that's readily apparent to what the workers' comp department needs them to ask and how they interpret it. So, work comp started in Wisconsin many years ago. Historically, workers, like anybody else who is injured, to recover and claim would have to show fault of the party that they allege was responsible. And in exchange, they had unlimited damages. They could recover pain and suffering and loss of consortium. One of the first states in the nation, we adopted this work comp system, and it limited employees' ability to recover all these extensive damages. They can't get pain and suffering, for example, in a work comp system. But what they can get is a system that's supposed to be efficient and to take care of them quickly. And they don't have to prove fault. Workers' comp is a no-fault system, so we don't have to worry, could the employer have been more safe in what they were doing? Could they have lifted more carefully? Could they have called somebody to help them when they were moving a heavy object? It doesn't matter for workers' comp. If they were in service to the employer, it's covered under the work comp system. Another issue that comes up is which employers are covered. In Wisconsin, almost every employer is covered under the work comp system. Some very small farms are exempt. Some independent contractors are exempt, but those are very rare. Almost anybody who's working for somebody else, even if they're being paid cash, even if they're called an independent contractor, and the workers' comp system, they're not independent and they're covered as a worker under the system. And then finally, even if the employer claims they're not covered and doesn't have work comp insurance, they are still within the system because they bring a claim in the work comp system with the uninsured employer's fund. So they're still going to follow the same system. It would just be against a different defendant, which is something you don't have to worry about, but they would still be part of the work comp system. There are three kind of major types of injuries that are recognized in work comp. And it's actually two, but I'm breaking out a third. So there's traumatic and occupational. And traumatic injuries are injuries that occur a single day. So, and a single instant. So somebody gets whacked in the knee with a cinder block. Somebody lifts a very heavy box, feels an immediate onset of pain, and can't do anything further. Somebody slips and falls on the floor. Those are traumatic injuries. We know exactly what happened, we know the date, and we can see an immediate before and after. But workers' comp also recognizes occupational injuries. An occupational injury is essentially a lot of little injuries put together, and it arises, it wasn't originally in the statute, it kind of came about as recognizing if you can have one big injury, you can have little injuries that add up. So there are kind of three types of occupational injuries, things that happen through your daily work. One is repetitive tasks, so you're typing all day. This doesn't feel like an injury, but some doctors recognize this as causing carpal tunnel. Or running a jackhammer all day. I have a client who started running a jackhammer at 18, and at like 40, his shoulder started to get worn. So those are repetitive injuries. Then we have micro traumas. These are just basically a qualitative difference. So they're just like a repetitive injury, just the trauma is a little bit bigger. So you're repeatedly lifting and moving a 40-pound box, and every now and then they slip in an 80-pound, and you get a, ooh, and it's enough that you might report it, but you might not treat for it. So they're bigger injuries. It's not just the repetitive lifting the 30-pound box, but it's the occasional bigger injury. And those are called micro traumas. Those are also covered, and we look at all of them together as causing the injury. And then there's environmental exposure, and that's like working in an area with a lot of solvents, a lot of particulate matter, things that might cause you to get some kind of injury or disease separate from kind of a physical harm. All of these are considered occupational. The reason it's important to distinguish if we have traumatic or occupational is it helps us in assessing the date of injury. A lot of times employees get told, well, you don't have a work comp claim if you don't have a date of injury. Not really true. Occupational claims arise because you've been injured every day, and you may even treat for it, but your date of injury is the first date that you miss work for it, that you're actually taken off of work for the injury and you miss work for it. So if you're going and checking in after hours with your doctor or the urgent care or whatever, you still don't have a work injury because you don't have a date. Once you have a date, all that prior treatment is covered under workers' comp, but you do have a date of injury. A lot of people think, well, I don't have a date of injury. There wasn't one incident. You do. Your date of injury is when you treated. It's not when you had all these little microtraumas. And then the third type, which actually can be, is a subset of occupational, but I've scooped it out, is mental injuries. And these I've given a separate category because they're number one, rare, and number two, really hard to prove. Wisconsin requires a much higher level of proof for mental injuries. You have to either show that mental injury arose out of a physical injury. So you fell on the ice and then you have PTSD afterwards, let's say. Or you have a situation that's way beyond the norm of anything that would ever happen at work. So just kind of the stress of a difficult boss will not give you a mental injury claim. The kind of benefits that an injured worker can get, they get their medical bills paid, and not through their health insurance, so they don't have a copay or deductible. Their pharmacy bills, 2/3 of their lost wages. They get permanent disability as it's assessed by the doctor, and we're going to talk about that a lot more. Mileage to their medical appointments. If their injury is a certain type, they can bring something called loss of earning capacity, showing that they don't have the ability to earn the way they used to. Retraining, where we actually send them back to school. And then there can be penalties against the insurer for bad faith, if they deny it when there's no basis, delay in payment, or safety violations. And then when we're looking at assessing permanent disability, I kind of have to explain the system a little bit. We have scheduled and unscheduled injuries in work comp. So if you think of the body as a whole, anything outside of my torso is a scheduled injury. So from my shoulder, elbows, hands, hips, knees, feet, any part of my limbs is scheduled. And we have attached here, attachment B, the schedule, which I love to show to clients because it sort of creeps them out that every body part has a number. So the schedule looks at if you have injury to any of these limbs, we have just kind of an amount that the injury is worth. We give it in terms of weeks of disability, but a week is really a unit that's represented by a certain dollar amount each year. So you can just think of it as units. And when you look at 102.52 in the statutes and the schedule of injuries, what it's telling you is this is how many units of disability pay a person is entitled to if they have amputation at that part. So if you lose a thumb at the proximal joint, it would be 120 units. If you lose a middle finger at the second joint, it would be 20 units. So there's a schedule for every part of your body outside of your head and torso. And that doesn't necessarily come in to the opinion that you might provide on a 16B, but it kind of helps to inform you of how we're looking at it. An injury to the back, to the body as a whole, so to your lungs, a traumatic brain injury, a neck injury, all of those would not be part of the schedule and would just be rated as compared to the body as a whole, which is valued at 1,000 units. So an injury to the shoulder, which is 500, would be half as much as an injury at the same permanent partial disability that's rated to the body as a whole because it's, say, at the neck or the back. So that's just kind of to give you an idea of how we look at these two things. The only other reason that whether it's scheduled or unscheduled matters is that you can't claim loss of earning capacity if the injury is to a scheduled part. Scheduled parts are scheduled because they are meant to limit exposure. So even if, you know, you throw a ball for the NFL and your injury to your arm completely makes you unable to work, we're still only going to look at the loss of functioning of your arm. We're not going to say you're 100% perm total because it's scheduled. It's only to your arm.
Quick question on that.
Yeah.
When you say loss, does it mean you wrote amputation on there, but does it also mean just if there's no function of that
Yes.
digit or hand or?
So what you would do as a provider is you would rate their disability, and again, you don't need to look at the number of units, the judge will look at that, but what you would rate is as compared to amputation. So if they have complete loss of function, for example, let's say you can't move your thumb at all, so you have 100% loss of function, it's paralyzed, but having it there provides some use to you. You can pick something up and move it. Maybe you have 75% loss as compared to amputation because you have no movement, but it still exists there, and that might be of use. So it's always as compared to amputation.
There's multiple injuries that was cumulative.
Sort of, actually, multiple injuries.
Question.
No, that's okay. I wasn't going to cover it, but you are welcome to look. It's actually kind of a complicated calculation. It's not just added together, and it's in here. One of the sections that I've like squiggled out, it's in there. The multiple injury calculator. Oh, there it is. It's at 102.53, multiple injury variations, and you take the closer in injury. Within, you take a percentage of the proximal injury and then you add them together, and it's, yeah. So they are cumulative. So we actually ask for an opinion on each of the different injuries, and then we do the multiple calculation. Or actually, I don't even do it. We send it over to the workers' comp division, and they have specialists that do it. So when you're treating somebody who's been injured at work, there are a number of issues that you might face that are different when you're treating somebody who is injured, just around the house or in a claim that might give rise to a personal injury claim. One big thing is that unlike personal injury cases, in work comp, providers are almost never required to testify at a hearing or to be subject to cross-examination. In a personal injury claim, we ask doctors for their opinion, they give us a nice long report, and then somebody calls them into a deposition where the opposing counsel questions them a lot about their opinion and kind of berates them for the decision that they came to or the analysis that they came to, and then they put them before a judge and a jury. That never happens, or very rarely. I've seen it happen once in my almost 20 years. Doctors aren't called in because both sides don't want to pay to bring doctors to a hearing, and because we want our doctors to be kind of left out of it. It's supposed to be a streamlined system. So generally what happens is we give you a 16B form. In workers' comp, a WKC 16B is admitted in lieu of testimony at a hearing. So you have to sign the certification at the end, but you don't have to then come in and be present at a hearing. You don't have to, make the schedule for that. So you can complete the 16B, it helps you not have to appear at the hearing. If the doctor doesn't submit a 16B, sometimes either side, sometimes the carrier will say, well, we're going to call you to hearing, and then usually they submit the 16B. The provider can charge a reasonable fee for preparing the 16B, and they always do. The carrier also submits a 16B, and they do it through an independent medical exam, and just smack a 16B on the end. So, the 16B doesn't necessarily have to be filled out in its normal form. It can be kind of with a C attached report and then signed at the end, and they can just give a long medical form. And you guys can do that too. Anybody can do it that way. But the quick way and the way that's efficient and useful to the workers' comp department is really to just complete the 16B on the form, as long as you understand the questions that they're asking on the form. So some special considerations are that there's no need for a specific date of injury to be covered by workers' comp, and we talked about how a date of injury is calculated for occupational, but if a patient comes to you and they think, oh, it's not covered because I don't really know when it happened, focus on what the employee has told you is their exposure, and you can analyze from there. You don't have to have firsthand knowledge. Your opinion is supposed to be based on what the employee asserts, and the judge then makes a determination, is what the employee asserts fact? Did that actually happen? Did they actually slip and fall at work, or do we think it happened outside of work? They'll make that determination. Your role is to then, assuming that is fact, give a medical opinion as to whether that type of exposure could have resulted in the harm that we're seeing. The carrier does have a right to a copy of medical records related to the injury, and the statutes actually provide them the right to get a copy without a release. I don't know any providers that will give them a copy without a release, but I've heard of carriers trying to get them. The statutes allow them access to all records related to the injury, but I think as a matter of practice, we all still get releases, and the employees will sign releases for them to get the records that they need. The carrier sometimes appoints a nurse case manager, and that person will often want to come with the employee to appointments. They usually describe themselves as being a patient advocate. They really are not. They're an insurance carrier advocate. They're not bad people. A lot of them are very nice, and some of them actually do advocate on behalf of the employee, the injured worker. The vast majority, though, are their role as an employee of the insurance company is to reduce exposure and to get the people back to work sooner. So a lot of times they'll intervene to try and kind of assert their opinion on getting them back to work, which, sometimes getting back to work helps people stay active and get better, but their goal is not the same as your goal. Your goal is to get your patient better, and whether that's going back sooner or later, their goal is to get them back to work and reduce the amount of time that the insurer is responsible for. The nurse case manager will often try to sit in on appointments with the patient. Everybody has different opinions. Insurer advocates say that this is a good way to go. My opinion as a injured worker advocate is I don't think it's beneficial to them, and I don't think it's beneficial to the process of sharing information openly with your provider. However you feel, the important thing to know is you don't have to let them in. You have a right, and the employee has a right to say, no, this is a private medical consultation, and we don't want you in here. They have a right to talk with you, and they can call you afterwards, they can set up an appointment to meet with you, but they don't have a right to sit in on the appointment with you and your patient. Yeah?
If the patient requests it, does that change anything?
Well, if the patient requests it and the provider doesn't want them to, you mean? Then it's more akin to a patient wanting to bring their wife into an appointment. So I would say, do kind of whatever analysis you would do in that situation. Then it's, do you allow patients to bring in whoever they want? My hunch is probably, but you might just have a discussion with them before and say, listen, I think this might interfere with our treatment. If you really want them here, they can, but I'd rather that we talk one-on-one, and I can talk to your case manager afterwards. But the case manager is really not somebody that's hired for the employee's benefit. It's somebody that's hired to manage the case, not to manage the patient, really. Yeah?
Are there limitations to what you can then share with that nurse case manager in regards to your plan of action, what you're going to do for treatment?
As long as, again, they're not required to have a release. They're required, they can have the medical information without a release. So the corollary to that would be that information that you share, they would also not necessarily need a release. If you have a release anyway, you now have a release to give them information. So you should be able to give them unlimited information. I would probably document it so that sometimes what was discussed or what was recommended gets put into reports in ways that providers later dispute what was said. So I would kind of make a note of the recommendations that you discuss. I'm on point E now. The worker is entitled to lost wages only until they reach an end of healing. However, the worker continues to be covered for medically necessary treatment for as long as it's necessary. Sometimes it's their whole life. I have a client with a traumatic brain injury that's, been treating, her claim was over years ago, but she's continuing to treat. Now she's getting inpatient care, and she, as things decline. It doesn't matter that they're at their end of healing. And a lot of adjusters will tell the employee, well, end of healing, everything's done. It's not really true. It's kind of a intentional confusion of the issues. When they're at an end of healing, they would no longer get their lost wages paid. So after that, if there's a disability rating, they would get that paid out. And that would be it as far as disability goes. But the treatment, as long as it's medically necessary treatment, if it's continuing treatment, they're at a plateau, but they need some kind of maintenance treatment, that continues to be covered. So, if employees come in and tell you, oh, they said I can't, continue physical therapy because I'm at an end of healing, that's not really the case. As long as although one thing that is an issue is sometimes they're not really at an end of healing. Then, if the physical therapy is intended to help them maintain, then they're at an end of healing, and that's just after end of healing treatment. If it's intended to improve them, they're not really at an end of healing yet, and you need to look at your actual end of healing date if it needs to go out till after they've finished all of these other types of treatment that might somewhat improve their condition. Also, follow-up treatment, if the first line of treatment has issues, is also covered. So for example, or anything that's kind of consequential to the injury, even if this second thing didn't actually happen at work. So I had medical, that's not a good example, that happened at work. Well, we had a guy who had a back surgery and ended up getting a MRSA infection, and then had big treatment for the MRSA infection. The MRSA infection didn't happen at work, but it happened as a consequence of the treatment for the work injury. And it was a conceded work injury. So the treatment for the MRSA infection and the disability as a result of that is also covered under workers' compensation. It kind of goes as far out as necessary. So now I want to talk to you a little bit about the major steps in a work comp process. And I've put it down as linearly as I can, but what you have to understand is it often kind of goes like this. It's back and forth, and you might have this, another case might veer off in a different direction before it comes back, and some things might repeat a couple times. So the first, we have an injury. The first step for an employee is a first report of injury. They're supposed to make it in writing to their employer. The employer has a form. By law, they have to give it to the insurance company, even if it doesn't result in any compensation. Somebody falls and has immediate onset of pain slipping off their chair at work, the employer should make a report of it and send it on. And then it's there if something arises. Doesn't always happen, and if it doesn't happen, it doesn't mean you don't have an injury, but it's supposed to happen. Often then there's an initial medical report, which is called a WKC 16. No A or B, just a 16. That's often requested by the insurance company to the provider, usually in cases where it's not really a contested injury, and they just kind of want an initial diagnosis. It's not really a final report, it's kind of an initial report of, gee, what happened and what are you seeing right now? They'll usually submit a medical release with the 16 to ask you to kind of give your initial assessment of what's happening. Then we often have this kind of period where the employee's getting treatment. They might be, we are hoping that there's not going to be heavy intervention and we're going to put them back to work on light duty. And during this period, it's really important for the employee that they get return to work slips, noting what their restrictions are, their light duty, when, how long it's expected to last, or how long before they need to be reevaluated. And they really need to make sure they get those slips and take them to their employer, that they keep a copy for themselves because they have a way of going missing in personnel files. But those slips document the employee's time off work that they may end up having a claim for. It's called TTD, it's temporary total disability, or TPD, temporary partial disability. So if they're at work less than full time, those return to work slips are the documentation that's necessary to get them that benefit.
Can I
Yeah.
have a question in that regard? The problem I see though is that we ask for restrictions, and I don't know if this makes any financial bearing on the patient, is we ask for restrictions and the employer doesn't necessarily honor them.
Sure.
Or if they can't honor them, they just have the patient off completely.
Mm-hmm.
Happens a lot.
Yeah, so a couple of things. If they come back, the employee has to guard their own restrictions. If you give restrictions and the employer says, oh yeah, we can meet that restriction, we're gonna put them on desk duty. And then they put them on desk duty, and that involves moving banker boxes several times a day, and they're 40-pound banker boxes and they have a 10-pound restriction. The employee has the obligation to say, hey, I'll be here, I'll do desk duty all day long, but I can't move these banker boxes. And if they continue to insist on moving the banker boxes, then the employee needs to say, I have to go home. And they should then come back to you and say, can I move banker boxes? Here's a specific, can I do that? Or they can just say flat out no, and they should document it. The employer can also say, we're just not going to accommodate temporary restrictions. And there's no legal obligation to accommodate temporary restrictions. They can say, once they become permanent, then you may fall within the Americans with Disabilities Act, where they have to actually give an accommodation if it's reasonable. But while it's in the healing process, it's a temporary restriction, and they're not required to accommodate them. They are, however, required if they can't accommodate and the person isn't going back to work because of their refusal to put them back, they have to continue to pay their lost wages during that time. So the employee would collect 2/3 of their wages, but it's tax-free, so it works out to basically your full wages. Did I see a hand back there? Okay. So that happens almost all the time. I feel like it happens a lot more with small employers. Big employers tend to have good return to work systems in place, and they kind of watch carefully what the restrictions are and put it. Small employers often just really want them back. If they have a high deductible on their workers' comp insurance and they don't want to pay to have them sit at home, they'd rather have them pay to sit at work and answer a phone or something. And that's fine, as long as we're doing it within their restrictions. I'm trying to think for America. So the return to work notes are crucial in getting them back and being as clear as possible in those. When we say as tolerated by the employee, that often gets them into a lot of trouble. If it's possible to give really specific, the form that everybody uses, it has how long can you sit, how long can you stand. Filling in as many of those as possible is really helpful to the employee and to the employer in understanding what they can offer them. During this period, particularly if it ends up being a little bit bigger claim, if it's a smaller claim, often it'll be paid as long as they have proper documentation. If it's a bigger claim, like say they're going to need back surgery or knee surgery or any surgery or really extensive treatment of, even a prolonged course of physical therapy, that's when the workers' comp often looks at having an independent medical exam to see if they can cut off benefits. And I use independent in quotes. They are, like the nurse case manager, employed by the carrier. So often they're, sometimes there are a few good ones out of Madison that are actually, practitioners at the UW or something. A lot of them are, they really aren't practitioners and haven't been for many years, and they just kind of crank out IMEs. There's one that comes up from Colorado all the time, flies up and does 20 of them at a strip mall and goes back home. And they always deny claims. I've seen, a half dozen in the last almost 20 years that have not denied a claim, and it's almost impossible that every treating doctor is wrong. So they'll get sent to an IME. Sometimes they'll get sent to an IVE, which is an independent vocational exam if they're making a loss of earning capacity claim. They have to go to them. Failure to go to those appointments results in them being not covered. But they should know going in, they're probably going to get denied, and they're probably going to get handled kind of gruffly. I had a patient that was injured in the course of one of them. But they have to go to it. After that, they're often cut off from benefits until we can get them to hearing. And that will prompt us to get moving pretty quickly to get them to a hearing because they may need to get their benefits reinstated, or they might need that to get pre-approval for a procedure. Then presumably they reach their end of healing. Sometimes IME comes after the end of healing. This is again where things don't always go as linearly as this. Yeah?
Maybe you said this, but for an IME, who traditionally requests that?
It would be the insurance company.
The insurance company?
Yeah. The insurance company requests it, sets it up, and pays for it.
Is there typically a why behind that?
What's that?
Typically, why would
they?
Yeah.
They usually do it when it's a bigger claim. They cannot deny a claim. It's illegal for them to deny a claim. If the providing doctor has said this is work related, they can't deny it unless they have a medical basis for the denial. So they have to get a counter opinion that, you know, the doctor says, oh yeah, you know, that packing heavy forms all day long did result in some degeneration in the spine. Then they need to get somebody who says, oh, no, repetitive injuries don't cause spine degeneration. And then they have a legitimate legal basis for denying it without incurring a bad faith penalty. So that's why they do it. Smaller claims, they might not, because IMEs are expensive. And it's less expensive for them to just pay the claim if it's you know, unlikely to result in something really big. Yeah.
Go back quickly to